Bienvenidos a Hemispherics, el podcast de fisioterapia y neurorehabilitación, presentado por Javier Sánchez Aguilar. Hi everyone, welcome to Hemispherics. I'm with Susan Woll, physical therapist, creator of the Forzas concept, along with Jan Utley. This is the second part of the interview to Susan Woll. In the first part, we talked a bit about her biography, the Bobath Concept, paradigm shift, different experiences with neurorehabilitation, different topics. And now we are going to talk specifically about force use, that is the specialization of Susan, and obviously the concept she has created along with Jan Utley. She is present. I mentioned her because it's important to mention Jan Utley, although she's not here, but she is present. I think she will listen this interview. You will ensure it. And so, hi Susan again. How are you?
I'm fine. Nice to see you again, Javier.
How do you think Jan Utley will say about this interview?
Well, I hope I presented what we developed in the most honest and clear way, and I think she'll recognize that. You know, she was my teacher after Mrs. Bobath, and then we began working together, and we've worked together more than most couples have been married. We worked together since 1986. It's a long time. And now that we've come to that point where we're thinking about retiring, are retired, not handling clients directly anymore, yeah, it's hard to go back and remember what happened without including Jan. Normally, she would be sitting right here beside me.
We are going to talk about force use and the beginnings of force use. Also the sense of the birth of the force use, the meaning. So we can talk about Jan. We can introduce who is Jan Utley, how did you meet her, and how did you create the force use concept? Why?
Well, Jan Utley was one of the original NDTA Bobath adult hemiplegia instructors. She was there at the conception of what we would call the IBITA in Europe, the NDTA in America. And she was one of the instructors, along with Isabel Bowman, who trained most of the other instructors in the United States. So when I came back from Europe, having had the basic course with Mrs. Bobath and all of the, at that time, possible advanced courses with Mrs. Bobath in Switzerland. I took all of my courses in Switzerland. I didn't know what I should do next. I wanted to be the best possible handler there was. And so I got in touch with Isabel Bowman, who was the head of the NDTA at that time, the elected head, and Jan Utley, with whom she worked. And I offered myself. I said, you know, I want to learn more. I want to do more. I don't particularly want to be a teacher. I want to be the best possible handler I can be. And I thought they heard me. Okay. And they allowed me to come to a course. And I, having trained with Mrs. Bobath, waited for them to approach me and talk to me and say whatever I did in that course was good enough to start assisting with them and learning from them. And I was very shy. You can hardly tell that now, but I was very shy. And day 1 passed, day 2 passed, day 3 passed of a 5-day course. And on the 4th day, Isabel Bowman came to me and she said, "Dear, didn't you want to talk to us?" And I thought, okay, now I can talk to them. Anyway.
You passed the barrier.
Yeah, exactly. And after that, I began assisting them in courses. And each time they attempted to trick me, that means I couldn't help in the course and learn how to be a better handler and hear all the material again unless I presented some form of lab or educational experience. So over the time that I worked with them, I actually did 36 basic courses over a huge number of years.
36.
Yeah,
oh dear.
so you can imagine. Oh yeah. And by the end of that time, I had given every part of the course multiple times. And at some point, Jan Utley came to me and she said, "You're like an overcooked cake. You are an instructor now. You have done everything. We're going to have one last course in which you and Beth Fisher will participate. And after that, you'll become instructors."
Mm-hmm.
So that's how it happened. And after that, I thought, no, I am never going to teach a course without Jan or Bo. I'll just wait for them to call me. I'll just wait. I'm not good enough. I'm not going to do that. So I waited, and it didn't take very long till Jan Utley called and said, the person who is supposed to assist me is sick. Don't you want to assist? And that was sort of like the beginning. After that, we worked together until now, from 1986 until now.
Mm-hmm.
But I would have never given another course. I would have never given a course alone unless she hadn't then taken me under her wing. And then we began teaching together under those conditions. And Jan, having been a professor in the university, we were very much involved in reading what was then the new neuroscience of the 90s. The 90s, you have to remember, was deemed the decade of the brain. And in that time, a huge amount of money was given for research in the areas of head injury, plasticity, stroke, etc. And
animal models.
Yeah, exactly. And so we kept up with that. And on the basis of that and reading that material, we felt that was also a time when we were introduced to the results of Dr. Taub's research. Mm-hmm. We felt it was our responsibility to keep changing the handling strategies to match what we called the new science or the new data on how plasticity occurs. And so we began making, our first changes were in intensity, more work against gravity, more work in the upright posture, more work in that way. And that was the beginning. And we worked together for many, many years.
So you went beyond what you learned in the courses. You introduced all these neuroscience studies with Jan, I think. And that is, go beyond the basic courses that you were involved and also the basic Bobath, I think.
We felt
the next step.
Exactly. We felt that Mrs. Bobath had actually given us the responsibility of doing that. Mm-hmm. She always said, the more science there is, the more you will get to the end point of recovery better. It should help you know how to help the client recover more fully and more quickly. And we felt that was her anthem, and that was actually what she gave to us. It was like the ability to go on. It was okay. We didn't have to ask anyone's permission. We believed that it was the right direction to go because it was still about the basic philosophy, trying to help the client recover motor control.
Mm-hmm. Okay. We are talking about force use, but maybe very few people probably know what force use is. Maybe the people can get the wrong idea that we were talking about in the last in the first part of the interview. This confusion with the literature, what is force use in the literature. So, how do you explain what force use is to a newly physical therapist who knows basic Bobath, Perfetti, IBITA, but no more? How do you explain it?
Okay, so this is very interesting for us because, as you know, the name of our course is the clinical application of forced use.
Mhm.
And clinical application is the very important part. So we developed management strategies that had the characteristics that were identified in the research in plasticity and recovery. We defined forced use paradigms, that means the management strategies, as strategies that would disallow overuse of the less involved side and encourage use of the involved side. So that tells you something about what we were doing. We weren't separating the body segments, taking them apart. If you had 2 legs, you had to use 2 legs. However, we were going to create strategies that forced the person to use the involved leg more. It had to be part of the strategy, and it didn't matter what activity we're talking about. Let's talk about sit to stand, because it's the one that everyone can fantasize, since all of us do this every day, hundreds of times. We encouraged or set up a treatment or handling situation where the less involved leg would be on a stool in a bad alignment, not in line. The knee would not be in line with the hip joint. The foot would not be in line with the hip. It would be hard to put all the weight on it to stand up. The other leg would be in a perfect alignment. And when the person leaned forward to change the base of support from the buttocks, from the hips, to the foot as the primary base in standing, most of the weight had to be on that leg. And so we forced the person to stand up using the involved side. That's what we called forced use, or a forced use paradigm. And in every activity, all 5 body segments are involved, but the involved body segments are required to be successful in the activity.
So the fundamental idea is to force the extremity to activate. Also, in very severely patients that we do know how to activate the muscles, we do some open kinetic exercise, but we don't feel any movement, and we waste the time doing passive mobilization and so on, and the patient goes to home every day with the same functional activities. So when we take a picture of forced use exercise, what would it be? What would it be?
The first thing you would think of is the person is going to work against gravity. That on
So
this planet,
standing, I mean.
It's in high sitting or standing. The person has to move themselves and hold themselves against gravity. It's one of the fundamentals when you live on planet Earth. We have gravity, and we have to overcome the weight of our body plus the pull of gravity every time we hold ourselves up. So that's one thing that you would see. Somebody is going to be more or less in the upright posture. The second thing you would see would be the involved body segments in the closed chain. Okay. So using systems in the body that do not require the client to understand the movement, do not even require the client to actively participate through cognition and intellect. Just putting weight over an extremity in the closed chain, you have the potential for activating or stimulating skin receptors, which are then processed on a spinal cord level in 45 milliseconds to initiate muscle activity. The client doesn't have to be part of that. You would like them to be part of it and enjoy it, and maybe get sensory feedback that also helps the person to become more and more cognitively connected. But for initiating muscle activity, it's not a requirement. So you can do this with a client who you feel is not cognitively active or understanding or processing verbal communication. So that's one thing you would see. You would see the client using the closed chain, whether it would be in the setup of the activity. The foot is on the floor always.
Always.
The other foot, always. The foot is on the floor. The other thing you would see is the upper extremity is in contact also.
It's integrated, always the upper limb, yeah?
upper limb is always integrated. It's not something you wait till later for. What we think about is this: synergistic organization. Okay, when you think about the connection of the muscles of the leg, we know that the muscles of the hip, which are the strongest muscles in our body, connect the leg as the primary base of support with the trunk. They cross over at the hip to the lower trunk. So we know that if I activate the foot and I start a process of activating all the muscles in the leg, I also have a connection to the trunk. Then when the trunk becomes activated, I have these continued lines of communication where I have the synergistic organization that can connect all the body segments. So the closed chain is a very important part of this. It is a form of facilitation. Facilitation usually is thought of as something like using skin receptors. That's true. Sweep tapping used skin receptors. It's a phasic response. Tapping on the body, the muscle belly was a phasic response, on off. But it didn't make a connection to other muscles that were connected to the muscle that was facilitated. So as soon as the facilitation, the active facilitation stopped, the manual contact, there was no more muscle activity. That's different in the closed chain. It's also a form of activating skeletal muscle through skin receptors. But as the muscle activity is initiated, you have a continuation of muscle activity that's not phasic, because you have approximation in joints, movement in joints, change in length in muscle, all of which are processed at higher levels. So you have a much different situation with this form of facilitation than you have when you facilitate one muscle and agonist. We're initiating muscle activity in chains of muscles, agonist and antagonist, for graded control against gravity. So
facilitation is highly influenced by what we understand by facilitation according to Bobath. So what are the differences from what we can see in Bobath books or courses to the facilitation in Forzas?
Okay, so we've changed the definition. It's not about one muscle being activated manually, right? Which was actually facilitating the contraction of a muscle. Now we are facilitating the contraction of a chain of muscles, okay? And the agonist and the antagonist were graded control. So we describe or define facilitation as activating muscles to make it easier for the client to move him or herself, okay? So I can put my hand on the person at the same time to activate certain groups of muscles. For example, in the low back for extension of the trunk against gravity. At the same time, the client is in the closed chain with the leg on the floor. So I get a connection with the muscle activity that's coming from the floor up to what I'm activating in the trunk. And what do? I make it easier for the client to then move him or herself up into a transitional movement pattern or through a movement pattern. So it's always different in that way.
Yeah, Susan, it's always said that in a closed chain, the activity of all of the muscles is needed versus the open chain. This is what is teaching all the universities, I think. But we do not get inside this concept in the clinical practice, I think. Someone could ask you, how can I, with only my hands, handle a whole body, legs, trunk, arms, to do this closed kinetic chain and involve all the body segments?
Well, the easiest way is to put the feet on the floor where they belong. If I'm going to hold me up against gravity and I want to teach my client to stand, it would probably be good if I activated the base of support. So even when I'm alone, I have the possibility of using the floor to activate the leg. I have the possibility of two hands where I can actually use one maybe to help activate the skin receptors on the trunk, and maybe one to help with the muscles that are supposed to be the strongest for connecting the other body segments, the trunk, the arms, and the head and neck segment to the legs. I have that potential. But the greatest asset is using the floor to activate the legs. Or the contact with the floor in closed chair.
And also a good skills of handling, because when I see you handling a patient, you use what do you say, tatas is the very good concept. Everything. Can you explain what tatas is to the audience? Maybe they didn't know.
Okay. In Spanish, you would say saca pecho, lift up your chest. Okay. And some people can connect with lift up your chest, and some people think they've got their chest lifted and think their trunk is straight. We like to, or I like to, I'll put it that way, paint a picture for the client of movement that does not require a high level of cognition, of intellectual understanding about movement. So I usually use a body segment or a picture. So lift up your tatas would be lift up your breasts. Okay. All the women know where their breasts are, and they all know the difference between breasts that hang toward the floor or up. It's just a concept, and it's just a way of talking that connects immediately with the client and not require a lot of thinking about what does she mean when she says that. When I ask a client to extend their trunk to get straighter, I don't say extend your trunk. I say grow. You need to grow. Get a little taller in this room. I'm painting a picture about movement that doesn't require a lot of understanding about movement.
Yeah.
From the side of the client.
Yeah. Hence the importance of developing manual skills to allow the patient to do this intense exercise with the necessary help. But maybe some professionals do not have this manual skills and do not allow the patient to do some exercises because of the very affected arm or legs or so on.
Yeah, management. Actually, Mrs. Bobath said this. I mean, I learned a lot from Mrs. Bobath, including the ability to go on and continue to develop. She used to say that handling was an art to be learned. It wasn't just a scientific skill, and you had to meld science and art. And handling is an art. It's the understanding of movement and making what needs to happen clear for the client so that the client can, with you, participate. So one piece is facilitation with what I say. You need to get taller. What I do with my hands also needs to give them the impression of getting taller. I match what I do with my hands to what I do with my mouth or how I give information. But yes, it requires an understanding of the movement patterns that need to be developed.
We must show security in what we say, and our hands, the patients feels that.
They should feel safe with your handling and with the setup of the activity. So we many times build a situation where the hands are on something in front. Maybe a second bed, adjustable bed or table, which closes the space around, puts the arm as the anterior part, the front part of the base of support. So the center of mass never has the possibility of going outside of the base. What does that mean? The client doesn't perceive him or herself as falling. Visually, there's a table in front. There's a table in back where the person is in high sitting, like as if he were on a bar stool. And or one of the therapists is to the side of the involved side. So the client is sort of enclosed in a space. And in that space, he can allow him or herself to move with our help.
You speak about the relevance of the kinetic chain, the closed kinetic chain. The relevance of kinetic chain is based on neuroscience. What could we say about the muscle activity that is generated? We speak about concentric, eccentric, isometric. What activity are we going to reach with these paradigms, with these Forzas paradigms?
Okay, so we know that just by having a contact in the closed chain, I initiate muscle activity. Initiating muscle activity is primarily going to be a concentric contraction. Okay. It's not a huge and strong contraction. So the contraction needs to be continued over time, right? The good thing is we're not talking about one muscle, we're talking about agonist, antagonist in that chain. But all the muscles are activated at the same time. Okay. Then we know something else. We know that in the mid-range of muscle length is the easiest place for the client to get muscle activity and continue muscle activity. So when we set up the activity, we don't set the person up with 90 degrees of flexion at the hip and 90 degrees at the ankle and the knee, because then the muscles are getting close to being maximally elongated. So we set the client up sitting higher. So if he's sitting higher, the hip isn't maximally, the hip extensors are not maximally elongated. The knee is not maximally elongated, and the same at the foot and ankle. So at that point, it requires yet less strength for the client to begin to move him or herself. We can even do this almost standing, so that the range of movement is controlled. How much strength do I have to produce to move myself, and how far? So those are all parts of how I'm going to use the situation and the closed chain, my ability to get muscle activity. Just remember, the closed chain only gives me initiation in the beginning. If the client doesn't get weight bearing at that same time, he doesn't continue the processing. So getting a movement to occur or helping a movement to occur is very important. Getting more weight is very important. And every time the client moves over his or her foot, there's also a reinitiation of activating skeletal muscle or initiating muscle activity. So the closed chain becomes a very interesting concept in the initiation of muscle activity, but also maintaining muscle activity over time. And then I could add that while the client's doing this and holding him or herself up against gravity, they're strengthening themselves. They're strengthening those muscles. They're getting sensory feedback as they're moving around in the joints and changing length and muscle. So there's a lot going on there, but the structure of the setup itself needs to be accommodate that it would be possible to move me against gravity. That means the range of movement is limited. Okay. The person is closer to the end range of the activity than they are to the beginning of the activity.
We can establish a progress between the isometric activity to the maybe eccentric, concentric.
Okay, that's the second part of the answer. I almost forgot. Okay, the second part is this. When I have the muscles activated and I'm activating agonists and antagonists, I would like to maintain
the co-contraction, right?
Contraction, isometric holding around all of the muscles, that which we call co-contraction, because it's not one muscle, it indicates a group or a whole chain of muscles are being activated at the same time. So we call it co-contraction. And from co-contraction, I have the ability to make eccentric or concentric muscle activity. I have to start from a certain level of muscle activity. I can't elongate from nothing. That means I can't hold in an eccentric way to return to sitting, for example, from no muscle activity. I would just collapse. But if I want a controlled movement, I have to have muscle activity. So we start with co-contraction with movement. That means the person is moving over the foot, but the hip, knee, and ankle are making very small intrinsic changes maybe, but not big changes in range or non-perceptible. So the definition of isometric is not visible changes in length in muscle activity. So there are slight adjustments, but there's not visible changes in length.
Yeah.
So we start there.
Yeah.
And then we go from there to eccentric. I move with control into gravity through short ranges before I expect my client to lift his whole body weight and the pull of gravity up, which would be concentric.
Yeah. Speaking about the co-contraction, there is an interesting concept. Maybe there is a confusion with the pathological co-contraction that appears when the patient wants to activate an agonist and the antagonist activates. So there is no movement, active movement, or visible movement. So maybe we can differentiate the two concepts to avoid this confusion.
Probably. I mean, I think that's probably a good way of trying to begin to encapsulate the two concepts.
The contraction you are speaking about is always in closed kinetic chain, right?
Yes.
We can differentiate it between the closed and open. If we have a co-contraction in the open kinetic chain, maybe it is pathological.
Exactly. Because usually in the open kinetic chain, open chain, there is a difference in muscle activity and the amount required throughout the whole pattern. For example, if I go to reach in the open chain to get something off the shelf, at the shoulder and proximally, I have to hold more. I have to be able to stabilize to allow the distal part, the arm, to move and make adjustments. And then there's the elbow is more like the knee. You have to make adjustments. And then the hand and on the other, at the wrist, has to hold more to adjust where the hand is. And then the hand makes adjustments again around an object. So in the open chain, there's a lot of place for a disbalance between the agonist and the antagonist to occur, which would indicate that there's always going to be differences between eccentric and concentric. The problem is what we know in the arm is that the strongest muscles are the flexors. For medial rotation, for elbow flexion, for hand holding something, the flexors. As long as we're in the open chain. If I was a quadruped, if I was a dog, the extensors, which are mostly in the closed chain for running and pushing against gravity, were the stronger muscles. Now we're standing up. And we're using our arm against gravity in a different way. And the flexors have become the stronger muscles.
I remember the rubrospinal pathway that is very controversial. I have an episode. The first episode is talking about the rubrospinal tract because some authors say that it's a vestigial. I don't know if it's in English, vestigial.
Yes, the exact same word.
Vestigial pathway. I think I read it in John Krakauer's book, The Broken Movement. But we in the books that speak about the rubrospinal tract, they say that this tract helps orientation for the reaching, which would not be present in the closed kinetic chain. So maybe there is a justification of neuroscience for the both kinetic chain that can justify this physiological or pathological ways to movement.
Yeah, I read that in his book and I thought it was totally interesting. However, we still have that situation that our function with the arm, which is inherent to our lives, all of the functions our clients want to do, all the functions you and I do the whole day, whether it's from gesturing or using our hands to manipulate objects or any other kind of activities, require actually both arms to be coordinated with one another, and mainly, not like in our training, when we are initiating muscle activity is in the open chain. And we can call it the gray zone of open chain if I have something in my hand so that I have a contact, which makes it a little easier for me to grade activity in my hand. But the rest of the arm is in the open chain, let's face it. And that means in training that we start in the closed chain because we need to get and activate and strengthen muscles. And then at some point, we have to develop more and more strength, enough strength in the shoulder, for example, to lift this extremity against gravity and then be able to use it in the open chain. I usually call reaching, which is that moment in time when you change from the closed chain to the open chain, the holy grail of therapeutic intervention for the arm. If you don't get to the holy grail, you don't get to reaching, it doesn't matter what you've developed in the arm. You can do everything with one arm, it's clear. And the other arm can be in weight bearing and increase the size of the base. But most manipulation of objects and its function in daily life requires both of them.
And also speaking about co-contraction, what happens with this co-contraction when we have muscle shortening, especially in patients who sit all day in a wheelchair? How do we manage this muscle shortening and the relationship with co-contraction or muscle activity?
Well, the first thing I would say to do is it requires active mobilization. Okay, mobilization, whether it's for joints, joint capsules, or any kind of connective tissue, including the perineural tissue, the covering of the nerves, which is usually one of the main problems in people who are sitting all the time, whether it's nerves, the tibial nerve, the sciatic nerve, or whether it's the biceps or any of the muscles around the shoulder or the scalenes, whatever that is, that needs to be stretched. All connective tissue needs to be mobilized. And when you realize that even when you look at perineural stretching, which is unpleasant, nobody likes to do it, it causes pain because it has to do with the nerves. On the other hand, the more squeezing of the nerves you have by perineural tissue, the harder it is to activate muscle, and the harder it is to get a more optimal type of sensation. So mobilization is something that has to be done, in my opinion, from the very beginning with the client. You know, connective tissue begins to be stiff after 24 hours of immobility. Most of the time when we get clients, 2 weeks later, maybe 6 months later, still in a wheelchair coming to rehab, whatever that is, the potential for having multiple areas of immobility and stiffness that disallow your ability to, or influence in a negative way, your ability to get muscle activity is very large. In fact, it's one of very main issues. We've developed a form of mobilization where the client is in the upright posture, the feet are on the floor, the legs are being activated the entire time, and the client is then involved in moving dynamically as part of the mobilization so that he has theoretically the potential to learn a movement pattern at the same time the mobility is being reestablished. So there is a bridge between muscle activation, moving against gravity, and mobilization.
Yeah. So knowledge about changes in connective tissue is used in Forzas is taken into account. I remember that in the course, in the basic course of Forzas that we are doing at SEN, you spoke about a German author who did studies of this topic. I think. Could you tell us about this author that I don't remember the name?
He's a Dutch person. He's a Dutch person. Okay. Bert van Wingerden. He wrote a very seminal book called Connective Tissue in Rehabilitation. It's been translated into multiple languages. Okay. I don't know if it's still in print. It's not an old book. It was probably from the 90s or the beginning of 2000, where he actually looked at changes in connective tissue in all types of clients, including people who had strokes or head injuries, using biopsy, muscle biopsy. Mm-hmm. And then what he did was, I'm going to shorten everything. What he did was use 3 conditions of practice. One condition of practice was passive range of motion. Therapist goes into the room and moves the arm passively. We all learned how to do it. We just have to accept that as truth. Okay. Another condition of practice was asking the client to move. Straighten your knee, which obviously our clients couldn't do. Mm-hmm. And then there was using weight bearing and having the hand, for example, as a fixed point, and the person moved around their hand as a fixed point as a way of stretching the elbow, getting more shoulder flexion, bending forward and moving back. The same thing with the leg, bending over it and getting more dorsal extension, coming back. So causing changes of length by moving over the hand or the foot as a fixed point. And afterwards, they looked at, again, with muscle biopsies, the changes in the structure of the fibers in the muscle. And the only place where they found a reduction of stiffness, or the changes that stiffness caused in the fibers, was when the person moved over the hand or the foot as a fixed point. So the person had to be active and cause changes in circulation in the tissue intrinsically, rather than us moving everything and the person was a passive recipient. It didn't change intrinsically. That was his hypothesis, that passive mobilization didn't change or stimulate any internal structures to reestablish changes in tissue that happened when the person moved actively over the hand or the foot as a fixed point. Even if you were helping them, stretching at the same time, that was the only situation that changed the tissue and caused more fluid to be in it and the tissue to return to its more normal state. Mm-hmm. So that was something that helped re-establish our belief that we needed to do mobilization in the course. We had started doing mobilization in the course on a low level. Mm-hmm. Obviously, the ankle, all therapists stretch the ankle in some way. It was usually in the open chain. And I remember when I was seeing children, pediatric clients, teaching parents to stretch the ankle in the open chain and just push against the forefoot and pull down on the calcaneus, et cetera, et cetera. Those kinds of things. But this changed everything for us, really starting to figure out how to get, use the closed chain to get the client to be more dynamic, even when the client couldn't 100% understand what he needed to do, maybe didn't have verbal processing wasn't problematic, but how we could do it with our hands and the setup of the activity to help the client to be more mobile.
Mm-hmm. Yeah, I agree with you that there is a big difference between open and closed chain stretching and mobilization. There's a very great difference that we can notice in the clinical practice every day, I think. Yeah.
Even in our activity that we call bridging, when you think of the position of the arm, it's lateral rotation, the elbow is toward extension. We have wrist extension and the hand open, whether it's over an object or flat. In that activity, when the person does the bridge and moves away from the arm as a fixed point, they're involved in perineural stretching as well as all other stretching. And so doing those activities helps also to reduce how much you have to do with individual stretching of one group of muscles or another.
Okay. I want to ask you something. It happened to me that before, years ago, I understand what the closed kinetic chain is and weight bearing, but I didn't know how to formalize it into exercises until I learned about Forzas, that I see Jose, the people at Zen and other clinicians. What exercise ideas could we give to give the audience an idea of this exercise? Maybe we can talk about breathing that you have mentioned, which is an exercise that people know about, but not in the way that is used in Forzas. So what ideas can we give the audience to understand this closed kinetic chain exercise and weight bearing?
Okay, this is a problem because when I talk about bridging, it requires a huge amount of art in the handling and understanding in the handling. But what I would like to talk about maybe is activities that you can do in standing, okay? For example, so the standing is clearly the closed chain, but the hands can be on a table in front, or the hands can be on a ladder in front. But let's say the hands are on an ironing board. Typically, not everybody has 2 or 3 adjustable electric mats, mat tables at their, to use all the time. So we usually use something like an ironing board in front of the client, which is an object of function that most clients know about. It makes them feel comfortable. And I see it as an adjustable table. It makes them feel comfortable because it's an object from home. It's an object from before the stroke. I can have my hands on that in the front and it can be higher. And then the client is in the closed chain with his hands. I would have a stool in front, a little step stool, and a stool to the side or a ladder to the side. And under those conditions, the person is standing using the closed chain, but with the less involved leg, he can move around, he can use mobility, he can use like what we would relate to the movement of the leg in walking. It would be the swing leg. He could step from one place to another, up to a second step of the ladder, which is at the side. And if I do that, I'm working on knee extension. I'm working on hip extension. I'm working on the sagittal plane, the frontal plane, and the transverse plane, all the muscles around the hip. So when I make a step from the ladder at the side to maybe a footstool or a ladder in front or a little step, I'm looking at all of the planes in the hip using the closed chain. So I'm strengthening the hip against gravity. I'm working on endurance. The client is up longer. Okay. And I'm working on stability, using the arms for stability or for balance, which is a function of the arms. And I'm working on the leg in weight bearing, which would be the stance phase of gait. So that would be a closed chain activity where the one piece that's moving in bigger ranges is the less involved leg. And I can change the patterns. I can step to the side even farther. I can step back and put the knee down in the back, like on the mat and back where the person had been sitting. The knee can be down, the foot is back. Then the person could push up and then take a step forward. So now I have the whole swing phase of gait. I'm moving from loading to pre-swing. So there are a number of ways you can look at that. So when you make up an activity, that's what you're thinking about. Which pieces need to be in the closed chain for strength, activation and strengthening? And how am I going to get movement to occur? The person isn't a statue. They're going to hold. And then I need to identify what I'm working on. If the person's main or principal movement dysfunction problem is weakness and instability at the hip, this would be a great activity.
Yeah, we always keep in mind this stability mobility binomial or co-contraction co-activation. This binomial has to be present in every activity, right?
Exactly. There's always movement that has to occur. And how much movement and how much adjustment in the stance leg, which is the leg that In the beginning, you want to be more toward co-contraction, and then I'm going to start adding range to the movement. So if I just stay straight, standing more erect, and step to the side with one foot and step back or forward, the stance leg remains relatively straight in co-contraction with very little adjustment. However, if I step back and the less involved leg is on the knee, then I have to make an adjustment at the hip and knee and ankle of the involved leg. So I start adding ranges of movement. The first range would be eccentric as the person steps in the back. And as the person starts to move the leg forward again and around, the less involved leg, then I need to move toward extension on the involved side. So I start adding co-activation with smaller ranges and then building toward bigger ranges of control.
Yeah.
So the activity itself has all of that built into it. And then on top of that, then you have your ability to facilitate the organization of the muscle activity as it's happening with your manual facilitation.
Mm-hmm. Always in Forzas, you say that the transition into activities is important. Also, the mere positioning of the hand between the ironing board to the camilla to the table is important. We have to take into account the transition between activities or into different rooms of the therapy.
Okay, so we believe that because in daily life we transition from one activity to the other, that one of our goals is that the client also can transition from one activity to the other. He takes a walk, then he sits down on the sofa, then he stands up and gets a glass of water from the refrigerator. So one changes. And I think that in the hospital setting, in the rehab setting, there's a lot of what we would call stop-start. The person gets rolled somewhere, then a transfer happens. Then there's something else that happens. And in between, the client just sits there and is not an active participant in changing from one activity to the next activity. So we start this from the very beginning on the smallest level. Even the difference between, I have the arms in front and there's been maybe some mobilization and the arms have been on a table, and now I'm changing to a new activity in which the arms are also going to be part of the base of support, but with more weight bearing, but in the back. So we try to keep the arm in the closed chain for the entire transition and make it possible for the client to be an active participant in the transition, like, for example, maintaining a contact with a hand, maybe on a board, some object, so that the closed chain is maintained. And then the client maintains, with our help, co-contraction and moves their arm through another alternative movement, maybe a strategy of turning the trunk. And every time the arm gets closer and closer to the back. So the client is an active participant in every level of transition, just like in normal life. And so that is the philosophical basis for that. And it's a whole quite a bit easier to begin another activity which requires more activity in the arm, not from zero, but from already a lower level of muscle activity. It makes it easier to continue and to go on.
It's difficult to keep in mind that for initial practitioners of Forzas, but we have to train it.
Think about that as something philosophical, and the philosophy that you're trying to develop into your handling strategies because you believe in it. So you're going to make yourself figure out how to make the client an active participant in his therapeutic intervention.
Yeah. In Forzas, these surprising objects are used, such as the ladder, the wheelbarrow. I don't know if this is the expression in English, the carretilla in Spanish, the ironing board, also the suitcase. What objects of daily life can we use to do these intense exercises, such as those done in Forzas, that you said in the part one that you don't use technology in your clinic in Switzerland. So what objects do you use to make this exercise happen?
Well, you've named numbers of them. We started initially working in the United States where the resources were limited. We didn't have, when I started, any electrical beds that went up and down. Only the ones who were doing orthopedics or the doctors had a few electrical beds. So we had to build surfaces up. So we started making up pieces of equipment. So we would get a box, and a box on top of the bed became a higher sitting situation. And the same thing with the grocery cart. We needed something to move, to keep the arm in the closed chain. And there's nothing better than an object of function to give the client the feeling that they're going to be well and they're going to go back to grocery shopping. So we use the grocery cart, we use the ladder, something that everyone has in their house, to change a light bulb, to wash the windows, to get to the highest level of the shelves in the kitchen, a ladder. And those kinds of objects. We use the wheelbarrow. A wheelbarrow is a wonderful object. Why? The hands are in the closed chain, but there's only one wheel. That means the arms are back in the function of not just weight bearing or the closed chain, they're in the function of balance. They're separated and you have one wheel. So you have to balance the whole time when you're walking. So that's sort of a progression. You would use something that's more stable, like a ladder, and both hands are in the same place on the side, and it closes the space in which I'm moving and working and makes me feel stable, to something like pushing a bed, to something like using a wheelbarrow to start working towards having less weight bearing on the arms, and the arms returning to the open chain or the function of balance. So all of these pieces of equipment are pieces of equipment that are from the house, from people's homes, from daily life, that people have relationships with. And those are the kinds of pieces of equipment we like to use, like an ironing board. Mm-hmm. And yeah, we use hammers. Or things with the arms. So you can hammer in nails, or you can use the hammer or a tennis racket so that I can work on pro and supination. Mm-hmm. So in fact, yes, we use non-technical devices, things that anyone has in their house. Mm-hmm. Or
they are very useful. They are very useful. We can do a lot of activities with them.
And if you see people in their homes, home therapy, these are the kinds of things you're looking for. And when you call on the phone before you come, you say, do you have an ironing board? Do you have a ladder? Do you have a step stool that you use to get into the closet? What do you have in your house? And you ask about all those things so you don't have to take them with you. However, they fit in your car, which is always good.
A few minutes ago, we talked a bit about how to activate a very severely arm with the closed kinetic chain paradigm. But how can an arm that is not moving at all be able to transition from the closed to the open chain? I know that it is a question that could be a whole course, but could you give some basic idea how to progress from closed to open chain, specifically for a very affected arm?
Okay, I'm going to tell you something, but it probably takes 6 months or 3 months, or put it this way, a bigger amount of time, whether it's 1 month or 6 months. But I'm going to tell you something about progression. So the first part of the progression is activating the arm in the closed chain, with less elevation of the shoulder. So or more extension of the shoulder, so you can also anchor the scapula. So it's a weight-bearing activity. You're anchoring the scapula, you're activating the whole arm distally. Then the arm goes in front and needs to be activated in different activities, maybe like a push-up activity, or just weight bearing in front with a lunge step back so more weight goes on the arm. But the arm ends up still distally being in co-contraction and extended, but there's a change in range at the shoulder. Now I have more elevation of the shoulder, which is like what you would like when you're reaching or you're using two hands together to manipulate objects. So I'm going to work towards elevation of the shoulder in the closed chain progressively. So it can be on something flat in front and weight bearing through the arm and strengthening the arm there by taking the other arm away, and then maybe strengthening it by forcing that arm to work harder, okay, by either taking a step or adding a weight, okay. The next piece would be to increase elevation. So what do we typically do? We tilt an ironing board against the wall and start working towards holding in co-contraction at different elevations. So the person has less, the arm is less a fixed point, and the person has to use the strength that he's already developed to hold the arm against gravity. However, the hand is still against an object. So you still have the benefit of the closed chain. And what you remember about the closed chain is this: the more weight I have on the fixed point, the more I activate skin receptors, the more muscle activity I get. So as I bring the arm up, I'm putting less weight through the hand. So I have to resort to using the strength I've already developed, because the closed chain isn't getting me a huge amount of muscle activity. It's activating muscle, but not at such high levels as when my weight was directly through the arm. So you're moving from a more automatic situation in the closed chain with the hand, for example, down by the body or in front and lower, to the arm is higher. It may still be in the closed chain, but I'm looking at now using the voluntary muscle activity that I've developed. So I'm moving up. I'm still in the closed chain. Yeah. And then I have to add changes in range where I hold. And then I have to start putting the hand, for example, on a mobile, potentially mobile object that I have to control and disallow from moving. And then I would have to start moving that object in my hand out of weight bearing, out of the closed chain. So it's a progression where I appreciate how much strength I need first to activate the arm and hold it against gravity. And then as I bring it up, where I have more and more elevation, I have to produce more force to hold the weight of the arm over time.
There is a beautiful key point between the reflex activation of the upper limb with the weight bearing to the voluntary activation of the patient. There is a very beautiful point, right? What do you think?
Yeah, it is the point. And the therapists themselves need to be, that's the, let me see, the art with the science, to appreciate how I can create that situation. So if I have a movable object like a heavy book, medical book, Kendall and Schwartz, the best neuroscience book there is, okay? If I have Kendall and Schwartz on my ironing board that's tilted and I have the client's arm on it, that book weighs a lot. That book probably weighs 5 kilos. What would I ask the client to do here? Not let the book move. I don't immediately go to moving the book. I put the book in different places and the client disallows it from moving. I'm building the strength against gravity so that I can move from that moment where I have to be in the closed chain, that I have enough strength to be in the open chain. And one thing that most therapists forget is that in order to do that, the scapula is primary. I have to stabilize or anchor the scapula. The scapula can't keep moving up, and I think that they're going to be able to, in a selective way, move the arm. The scapula has to be anchored against the thorax.
Maybe some therapists don't know about this concept of anchoring the scapula. What do you mean?
When I say anchoring the scapula, I mean that on an extended trunk, I have muscle activity that approximates the scapula against the thorax and holds it in depression and adduction, the neutral alignment of the scapula, which puts the glenoid fossa in an advantageous alignment up and forward at 45 degrees so that the humerus can make adjustments and move in that fossa, okay? And that the glenoid labrum is in an advantageous place for assisting to stabilize the glenoid, the head of the humerus in the glenoid fossa. Mm-hmm. If that doesn't happen and the scapula is moving everywhere and the glenoid fossa is pointing down, then I don't have a stable base on which to move the arm. And this is a very important piece because it's the difference between being a quadruped and being a human against gravity on 2 feet. And it was when I was a quadruped and I had the serratus anterior to hold as one muscle, the thorax against the scapula, and the hands in weight bearing, it was a different situation. Now I'm standing up. And now the scapula has to be held against the thorax, not the thorax against the scapula. And I only have muscles and muscle activity to stabilize the scapula and then organize the angle and position of the glenoid fossa for selective movement of the humerus.
Okay, always the stability mobility binomial. Yeah.
Exactly.
Okay, we are talking about exercises, ideas, but let's talk about your ladder model of clinical reasoning, because beyond the exercises, there has to be a clinical reasoning model. So could you tell us about this ladder model that is so I think it's very useful. It's my actual model. I think I have read about of neuroscience models and everything, but this is a very simple model that is very useful. So can you tell us about this model?
First, I'm going to tell you where it came from.
Mm-hmm.
I trained at the same time to become a Bobath instructor with a woman named Beth Fisher. Mm-hmm. And she was beginning her PhD at the University of Southern California. She's now a professor at the University of Southern California. And she used this model or created this model for its visual effect, first off, with students. It's a staircase. It looks like a staircase. There's a bottom step and a little up and forward is the next step, just like a regular staircase. And the initial idea was the students would recognize that each activity that you did with the client needed to build on the activity before. What I accomplished in the activity on the first step would allow me to initiate and build on the activity in the second step. So it was a progression. So that was the first thing. That was the initial beginning of it from Beth. And she used it with her beginning physical therapy and occupational therapy students to understand how to sequence therapeutic intervention, a treatment session, and how to get to a goal, a functional goal, because the highest step is a functional goal. So we're going to come back to that, but the important part about that is that every person would then look at the plan and say, what am I doing with this plan? It's not just about hip stability or making Bob, my client, stronger. It's about achieving a functional goal that will allow him to go back to his daily life, some part of his daily life that he really wants to get back to, whether it's putting on his pants and standing, whether it is washing a car, whether it is, and you can name washing windows, whatever it is. In the highest column, there would be an analysis of that functional goal, which would mean I would identify, or the student would identify, the movement components that were required to achieve or accomplish this goal. All of those movement components needed to be present in the treatment plan. So if I go back and look at my treatment plan, I could say, oops, I don't have anything in my plan for hip extension against gravity, or I don't have anything in my plan for bending down and picking up the pail so I can take it to put water in it, or I can wash the wheels of the car. Oops, I need to add an activity that helps me do bend and reach, because bending and reaching is about filling the pail, taking it to the car, and washing the wheels of the car, the lower part of the car. All of those have the same components. Oops. So this structure of the staircase was about organizing a treatment plan that allowed the client to accomplish something that he wanted to achieve. Within that, everything I ever wanted to achieve with the client was there anyway. Walking is there, bending is there, reaching is there, and now it's being all put together in a function. So by working on car washing, I'm not working on gait. By working on car washing, I'm not working on the arm. Everything is there, but I have a functional goal that interests the client, and the client knows what he's working on and also knows when he's accomplished it. Okay, so then it's organized in this way. Under the name of each activity, that means on the top of each step, I name the activities in order that I'm going to do. Underneath that, I have to justify it. That's my clinical reasoning. Why am I doing it? What are all the major movement dysfunction problems that I'm trying to solve with this particular activity? So it's movement dysfunction problems, maybe the main problem, and then the consequences of the main problem. And then the next step is to say, how will I organize it? So what will I do in this activity? How will I organize it? Then the third step is, what components of movement in the functional goal have I achieved here, or will I be achieving here? So I connect it not only to resolving movement dysfunction problems, but also to what I'm going to achieve in the functional goal. And that's what this is about. And so as you go along, it changes what I'm trying to resolve. Now I'm trying to not just activate skeletal muscle at the hip and the knee, but I'm trying to coordinate it while climbing the ladder, or I'm coordinating it while doing stair climbing. Those kinds of issues are all represented in this plan. So it's a plan that organizes your therapeutic intervention and really makes sure that you recognize that if my clinical reasoning is correct, I should be able to get to this goal.
On many occasions, we see that these steps of the ladder are the mobilizations, the preparatory activities, the mass practice, the adaptive training, and the functional goal. And all these elements are going to be linked to this clinical reasoning of the main problem, the consequences, the plan of the treatment. So what are the essence of each part of the mobilization of the preparatory activities, mass practice, adaptive training? This has to be a progression in the whole session, I think. And what is the essence of each part?
The essence of each part. So I'm not sure that I actually understand the question. So if I go off in the wrong direction, you'll just tell me. So we recognize that we can't establish controlled movement unless we have mobility. So in most cases, everything I need to mobilize, I will do first. That will allow me to achieve more optimal starting alignments for activities and have the range of movement required in order to achieve any of the other activities. So mobilization comes first, and that's the reason.
Yeah.
Then the next piece would be strengthening, okay, which is preparatory activity. Mobilization is also a preparatory activity. I prepare to do activity through, and you know, we just say preparatory activities, but actually it should be preparation for function.
Yeah.
And that's what we used to call it. And then of course you shorten it and you say, you know, preparatory activities, but it's preparation for function. So the next thing is strengthening. So activities that allow me to progressively strengthen places that are weak, that I've identified in my assessment as weakness, I'm going to strengthen progressively. Okay, so if it's the trunk or the hip, then I'm going to try to do as much strengthening, or the shoulder, whatever it is, I'm going to try to do as much strengthening as I can for any part that needs to be strengthened at the same time. That means I'm not going to just strengthen the hip and not strengthen the trunk. I'm going to try to, so in an activity like bridging, all 5 body segments are included and are being strengthened. So the hip moves against gravity. The trunk is extended and has to hold in extension against gravity. The shoulder is extended, the elbow is extended and having to hold the upper trunk up against gravity. So I'm strengthening the arm as well. So I have a coordination also between both sides in that situation also. So even when I say, why am I doing this activity? I'm doing it to reestablish hip stability in the transverse, sagittal, and maybe frontal planes, or whichever ones the clients have weakness in. I'm doing this to stabilize the trunk in co-contraction, in extension. I'm doing this too, and I have a list. One may be the main problem. The others are consequences of the main problem, but they're also weaknesses that have to be reinstated. And so as you go along, but that activity is not 100% against gravity. The person is not in upright posture. So the strengthening also progresses from being less weight bearing and less up against gravity to more upright, where I need to use my strength in daily life in the upright posture. So there's a progression of those activities also. So I might do a bridging activity. I might do a push-up activity. Then I'll probably do an activity in standing or 2 or 3 that also coordinates all 5 body segments, but is more toward the upright posture or in the upright posture and starts getting me into stepping and walking. So I have that as a strengthening piece. Then I need to do what? I need to prepare for the function. So I have to make sure that I have the client doing activities that uses the same ranges and the same direction of movement and the same organization as required in the goal. And then, of course, I have the adaptive training, the goal made easier, and then the goal progressively toward how it needs to be done or was done, has been done in the past in normal life, independent. So it's a progression. And I won't do the whole treatment plan on day number 1. I have to allow the things to happen that need to happen in each of these places.
Yeah. I think this model is a very, very good relationship between the physiotherapy and occupational therapy. Traditionally, the occupational therapy is the adaptive training purely, and physical therapy to activate the muscles and so on. No? But we have to link them. And the adaptive training is mostly forgotten in many therapies. So I think this progression is very good to accomplish the functional outcome.
Actually, this way of organizing the treatment plan has been probably the key to helping therapists move their clients forward toward function and not getting stuck on just doing mobilization and sending them back to the room, just doing mobilization and then bridging and sending them back to the room, and nothing moves forward. You need to see it as a whole. You're preparing for a function. And so all of the time you're working toward that function and talking about it with the client as well. This is for this part of the function. On Friday, we're going to do this piece of the function, like the first level of adaptive training. Even though the client is not ready to go outside and maybe wash the car, he is ready to maybe clean the surface of the mat table or clean the mirrors in the therapy or somewhere, something like that, where it involves using the upright posture and some of the movement patterns that are involved in washing the car.
Mm-hmm. We are ending the interview, so I'm going to ask you the 2-3 final questions. From your point of view, speaking about general neurorehabilitation, how do you see the evolution of the whole neurorehabilitation from the 70s to the current 2020s? How do you see in a brief phrase?
Brief, I have no idea. I'm telling you, in the 70s, we were trying to be better handlers. We didn't think of machines. Yeah. Okay, we were just trying to be better handlers and helping our clients survive and have a good life. We believed that. Then came research that told us actually we could do that if we were better handlers. If we were even better handlers, we could do that. We have to observe these principles of motor learning, the principles or characteristics of plasticity. But if we were better handlers, we could do it. Now we have machines, and I think the role of the machines should be to help us get to that final point more completely and faster. Faster, yeah. And faster. It shouldn't take, you know, when we used to see the client 3 times a week for 1 hour, we never achieved the number of repetitions or the intensity that we needed to achieve. So if the client achieved something in 10 years, I don't know if that was good news or bad news. By the time 10 years would roll around, the client doesn't believe anymore that he can get to that point of recovery and doesn't need to. And doesn't actually really want to, just comes to therapy because it's part of his life now and it helps him maintain his certain status that he's achieved. Then we had more intensity and clients actually started getting better faster. And I think now at this time, if we don't forget to handle the clients and also use the technology, we should get there more completely and faster. I think the great tragedy would be the tragedy that I see developing in many places. Rehab places that are only full of machines and there's no handling. And the clients are not getting better, just like they didn't get better in the 70s. And so that's a problem. For me, that's a tragedy. That's a problem. Yeah. Yeah. But insurance companies, especially in America, love to pay for machines, but don't love to pay for hours and hours of therapy. And we taught them that because in the past, we couldn't help the clients get better fast enough. So they didn't achieve the goal. And now they've been sold on the idea that the machines will help the clients get better faster. And that the machines in the end effect will cost them less than therapists cost them. So in fact, it's actually not about the clients, it's about money. Yeah. And it's a tragedy. It is a tragedy. And so I hope that's not going to happen everywhere, but that's a concern of mine. And that's why Jan and I and Marta Gonzalez and the other people we've trained to go on after we retire will still keep helping therapists become better handlers and help the clients actually recover motor control.
What do you recommend to a newly graduated physical or occupational therapy who has some interest in neurorehabilitation? What would you say?
They should take. I think they need to take courses in handling, so they understand motor control better. It's not that I'm saying to them they shouldn't use machines, but they need to see what motor control is and how they can influence motor control, because otherwise they won't know what they're trying to get on the machine. They're going to let the machine take over. The machine can't take over. It's only as good as the person who runs the machine and knows what you can do with it. So a therapist who doesn't handle and doesn't know what to do with handling can't identify how the machine technology can help.
Mm-hmm.
That's a problem. I wouldn't let a new therapist be involved with using machines until they actually learn how to handle. But I don't run a rehab center, and I know how difficult that might be.
Maybe it's the moment to back to the classics, and maybe that's the revolution, back to the classics, and do not forget the handling and the art of helping patients with our hands.
I believe that. I don't not believe in the machines, but I believe if we can't help them and don't know how to manage and treat our clients, we don't know how to use the machines to their benefit. It should be an adjunct. It should not be the main therapy.
Okay.
Okay. Thank you so much.
There is the final question.
Oh, okay.
Is a question that I have. When I met you, I have this question: what is the secret to reaching 70 years as lucid, as healthy as you are, with so much desire to teach and to work? What is the secret, Susan? Can you tell us? The red pill.
Well, there is no secret. The secret is having a positive outlook on life, recognizing that you're in charge of your own life. And if you believe in what you're doing, then that positive outlook keeps you energetic and then in control of what happens to you. So I feel that I'm in control of what happens to me, and that I'm not sorry about what I've done with my life. In fact, I am proud of it.
Mm-hmm. I want to finally say some words for Susan. Susan is an example of a life dedicated to helping patients. In fact, she's 70 years old, 75 years old, and still working. And anyone who sees her work sees that she works very hard. And for me, she's an example of an extreme therapist, a kind of extreme therapist. So thank you very much, Susan, for the interview. It has been a pleasure chatting with you and getting to know you a little more. So thank you very much.
And thank you.
And to the audience, thank you very much for following the podcast. I hope I can bring in more interesting professionals who will inspire other therapists and encourage them to study hard and to improve their practice. So let's see in the next episode. Bye-bye.